for the interest of time, we're going to get started with today's grand rounds. I'm going to go ahead and share the screen for introducing the MOC and CME credit statements. So for the CME credit for the session, please text 17029 to number 888-816-4893 as an SMS message. And for the MOC points, there is a quiz, and the link to the quiz is shown here, will again be displayed in the chat box. And you can use the room code 47 to log in and claim the quiz. And if the answer is right, you'll get the credit as an MOC points. All right, so with that two steps in place, now we come to our presentation for today. Is going to be given by Dr. Brajesh Patel. Many of you must be knowing him since he has visited us here recently. Dr. Brajesh Patel is currently working as a non-invasive cardiologist and a cardio-oncologist, and as an assistant professor at the School of Medicine in West Virginia University. In fact, it was very nice that I had a chance to see a bright young person who came our way when I was at West Virginia University, looking through the application for a faculty position. And one quality of his was his not only a great team player, imager, clinician, very sharp, but also he immediately won hearts of people out there in the community and became extremely popular. And he's very popular right now among the fellows and the faculty. He has level 3 training in echocardiography and also in computed cardiac computer tomography, cardiac CT. But more importantly, he has recently, in the last couple of years, distinguished himself by taking keen interest in cardio-oncology. He has not only created a track record there of attracting the patients, but also created a tremendous enthusiasm in research. He was very prolific right from the year I started, and won a NSF seed grant, which was awarded to him in July 2018. I still remember his application, which he was, despite his really busy clinical work, he was very enthusiastic and took it to heart and accomplished it. And he has subsequently won not only research awards and several accolades, but his commitment, despite his extremely busy clinical practice, to scholarly productivity is tremendous. He has over 90 publications, peer-reviewed publications in a very short period of time, an equal number of abstracts, and his commitment towards continuing in academic mainstream cardiology is commendable. So with that, today Brajesh is going to illustrate his mastery in not only his field of interest, cardio-oncology, but I'm sure he's going to make clearly home of how people, when they take interest in a discipline, can within a very short period of time, within a couple of years, get qualified and be known as a person to go to in the field. So with these notes, I put the podium to Brajesh for his presentation today. Brajesh.
Thank you, Dr. Sengupta. I'm sharing my screen. Just want to make sure you can see my screen clearly.
Yes, we can. Thank you.
Well, first of all, thank you, Dr. Sengupta and Dr. Yanamala, for inviting me. And it's always a pleasure to talk to you on any occasion. But I would say that this presentation is, some of the things we'll talk about is inspired directly by these two, the faculties. And, it's my luck that I'm being there in my audience. Generally, I've been on the receiving end. So thank you again for this opportunity. Without further ado, I'm just going to talk about about my presentation. And I titled it in a way: it's past, present, and future ways to detect cardiotoxicity. And as you know, Dr. Sengupta is running this theme of building paradigm. Now, I like that word, and I'll tell you why towards the end of the presentation. So you already been given this question. So one of the earliest, the paper I could remember reading as a budding cardio-oncologist is this one. So published in 1973, they studied 366 patients of patients who received anthracycline. Majority of them had Hodgkin's lymphoma, and 11 of them developed heart failure symptoms. Now the authors looked back and they said, okay, what happened? And you clearly see this chest X-ray. Needless to tell you guys, it's a patient had a pool effusion and dilated heart. But on the right side, there was a loss of muscle on the right upper panel, and then mitochondrial damage on the right lower panel. So I like this study because it looked at clinical, microscopic, and electromicroscopic evidence of cardiotoxicity. And they looked back and figured out what might have happened to this patient. And they found that anybody who received more than 550 had this problem. So 11 of them received 550 milligram per meter square dose, except one patient. But anyway, so this 550 number, we constantly learn, at least when I was in med school, this number was constantly thrown around, above which if you have a patient who receives more than 550 milligram per meter square, they are more likely to develop cardiotoxicity. But soon we learned that this is not the case. So the anthracycline, so on the left side, you can see, let me see if I can point. Okay, there we go. So here 550 comes, and you can see there's an inflection point, and after which you see sudden rise in risk of heart failure. So this sort of validated in that sense. But the newer studies have shown that any dose of anthracycline is cardiotoxic. So 550 is a number of past. So what we need to know is that anybody who gets any dose of anthracycline, they're going to get cardiotoxicity. As they are exposed to higher dosage, their odd ratios substantially go up. So no more we need to look at 550. Just start looking at this patient. Ask them in their clinical history if they've been ever exposed to anthracyclines, and go from there. So in the 1990s, so again, going with my title, past, present, and future, and I'll guide you. We're still talking about the past. In 1990s, the two main modalities of diagnosing heart cardiotoxicity were echocardiograms and MUGA scans. So needless to say, echocardiogram was still becoming very popular, and MUGA scan was there as a planar. SPECT is a newer generation, but there was planar nuclear imaging modality. And if you look at some of the early trials that studied anthracyclines and trastuzumab, cardiotoxicity was mainly detected by echocardiogram and still MUGA scan. So in the last few years, like last two or three decades, the echocardiogram and MUGA scan were still dominant modalities. Not to say that they were the only ones, but they were the major ones. MUGA scan was preferred modality for many anthracycline patients, and I still see orders being put in for patients who, let's say the oncologist who's been in practice for, let's say, 30, 35 years. They still prefer MUGA scan over echocardiogram, and we politely ask them and see if you want to change it to echo, and then we explain, the echoes have gone better. They know that, but still they want, MUGA scan. So that's okay. We still have it, but it's not very common. Echocardiogram, obviously, we know it's very workhorse for cardiomyopathy diagnosis for any kind, including cardio-oncology. And lastly, we have endomyocardial biopsy in 2000, I would say in early to mid 2000s, but we hardly do endomyocardial biopsies because of, the risk of, procedural risk, and other modalities are better. So now what about patients who cannot get this imaging? And some of the trials included troponin and natriuretic peptide as part of the evaluation. And it has been well established in animal studies, troponin specifically, and data on humans were equivocal at that time because the troponin was mainly used for myocardial infarction. On the other hand, natriuretic peptide, because it has a link with heart failure diagnosis or rule out heart failure diagnosis, it was widely used in early 2000s. So you will see a lot of tons of literature in the past about natriuretic peptide over troponin, but troponin eventually gained a lot of momentum, specifically high sensitivity troponin in the era of immune checkpoint inhibitors and tyrosine kinase. So now let's come back to where we are today. So because anthracycline was a main drug then in 1960s, 70s, 80s, and then trastuzumab came in 1990s. And then talking about today, we have tons of options, and this list is not even complete. You can, currently you can break down the cancer therapy in 4 classes, right? Chemo drug, you can have targeted therapy like tyrosine kinase inhibitor, immunotherapy, and then you have hormonal therapy like Arimidex. So we have a lot more options, and we need a lot more or different strategies to evaluate these patients because they have their own distinctive cardiotoxicity, and we'll talk about that. So ECG was one of the simplest and earliest tool, that you can use. Now we can, we're not there yet, but I think there are a lot of data. There's a lot of data that being thrown out from Mayo Clinic, Mount Sinai, some Italian groups. They're using ECG signals to detect asymptomatic heart failure and predict arrhythmia risk in the future. So it's going to come in a very handy way. But currently in cardio oncology mainly, apart from AFib and flutter and sinus arrhythmias, pauses, one of the major use of ECG is QT prolongation. So QT prolongation is, if you have a patient with a tyrosine kinase inhibitor, I think you should be evaluating them for evaluating with ECG for QTC. On the other hand, on the children's side, the left side image is on adults and children. Not just the ECG, but the QRS duration also predicts risk. So, example, if you have a patient with change in QRS duration by the amount that's here, there the risk hazard ratio is substantially going up higher. So the summation of what they did in this trial is they looked at QRS durations, and then they add them up, and they found a mean, and then that almost like a average signal averaging for QRS, and then they found that plus QT prolongations were predictor of cardiotoxicity. So ECG is handy, but it's not, you can just look at the ECG and just predict the risk of cardiotoxicity in current time, except QTC part. Now, if you have to ask me, what is the theme of the past? Past was more like, establishing clinical diagnosis after cardiotoxicity has happened. So what I mean by that is, that paper I showed you, and that was the theme for the most part, and a lot of clinical trials, they looked at the drop in EF or on MOGA scan or echocardiogram, or let's say QTC, for example. They were more focused on once the cardiotoxicity ensues. But currently, the current guidelines, and this guideline is from both the European Heart so this guideline was published from International Cardio-Oncology Society and collaboration with the European Heart Society, and they published in this journal. And what they're suggesting here is that if you have a patient who have higher risk, you need to get them more on surveillance strategy much frequently. Now, personally, I can discuss my why I don't completely agree with these, but I know what they're trying to say here is first determine their risk level, which is true. And how determine the risk? There is a classification by Heart Failure Society of America and ICOS, International Cardio-Oncology Society. They collaborated and created a scoring system. It's pretty easy to use, and then you just answer some of the questions, and that gives you patients' risk for moderate, low, moderate, and high risk. And then based on that, you see what they're getting, and if they're getting anthracycline, then, I don't need to go into details, but like, if you can see the patient with low risk, you don't need to get their echocardiogram very frequently. But again, we're talking about cycles. So cycle 1, cycle 4. So every 4th cycle, you want to get their echocardiogram. Now, it's fine, but I don't use this frequently unless there are some clinical features. If they have, for example, established coronary artery disease history, but then you can argue that, okay, they might be in moderate risk already. So why would you not get their echocardiogram? And I do get them, but I don't get the echocardiogram this frequently. But obviously, if they're very high risk, like if they had prior heart failure or they had a symptomatic heart failure recently and they need to get anthracycline or trastuzumab, I'm a little bit more aggressive. And I had a patient, in fact, who dropped her ejection fraction from being stone cold normal on multiple serial echoes while she was getting trastuzumab therapy. She was not particularly high risk, but then she had a drop in EF from 55 to 35. She underwent cath. Cath was normal. Unfortunately, this patient had a brain metastasis and she only responded to trastuzumab. Now, the oncologist was not comfortable and local cardiologist was not comfortable, and the cardio-oncology consultation was placed as an outpatient to me. I talked to the patient that, look, I mean, this is a severe risk. I mean, you know, the risk of further dropping ejection fraction is there, but at the same time, if we don't do anything, and this is the best therapy you have in terms of brain metastases and breast cancer, needless to say, we got her on more aggressive echocardiogram follow-ups. But the problem again was she was living 3.5 hours away from us. And if you don't know, but majority of the state is in a rural area, so it's not very convenient for patients, and our roads are not very straightforward. They are not flat. It can pose significant problems, especially in the winter times. So what I started using is more biomarker approach. So I did like biomarker approach on this patient. We started on aggressive heart failure regimen, typical GDMT, get an echocardiogram every few cycles and few months. And interim, I was getting blood work because it was easy to get, and she could go to her local lab and we can check her troponin and BNP. Ultimately, she followed with me in a year, and then her heart function has recovered, her brain mets were gone. But I think we can be creative with this strategy, but we don't need to be too aggressive unless in a particular clinical setting. So the theme of current time is early detection. So they want to use every modality or any way. If you think certain patients will be needs to be monitored more aggressively, then we need to follow them more frequently with an echocardiogram or biomarkers or MRI or whatever modality you choose. But I think the goal is to detect before it can happen. I mean, before it gets worse. But it is happening. So current strategy is to detect subclinical LV dysfunction or EKG changes and then treat before they manifest into symptoms. So just to give you an example, so let's see if I can click. Oops. So I'll show you. So, I mean, okay, there we go. All right, so there are two echocardiograms, and you can tell that ejection fraction on both the upper panel and lower panel, the ejection fraction is the same. Now, one thing I'll tell you, the strain imaging that were done in the middle column was not on DEFINITY studies. So the contrast was not used when we did calculate the strain, but the images after anthracycline were better on this patient with the contrast. So I'll just keep comparison. So anyway, so here, if you just ask me which of the two patients will have a higher likelihood of developing cardiotoxicity, I could not tell you, but strain really helped us in this patient. And I had an aggressive follow-up plan for this patient in terms of instituting GDMT at low dose, and then follow the patient. Then we repeated the echocardiogram. So this person, I don't have the follow-up echocardiogram, unfortunately, but this person at this time during anthracycline treatment, the strain was low, and the patient was followed up as an outpatient, and then the patient did develop cardiotoxicity here, and then the patient was put on aggressive medical therapy. Now you might say why the GDMT was not started here. The data, the SUCCO trial at that time was not out, and data on using preventative medicine is not that clear, unfortunately. But you can see that strain can definitely help. So strain was the modality we commonly use in our practice. We use strain imaging on every cardio-oncology echocardiogram unless they have a technical difficulty issues. On the other hand, the bottom image, the strain was completely normal, and this patient actually followed up with me last week. with an echocardiogram, and this echocardiogram, the echocardiogram from last week was very similar to current echocardiogram. So strain has a very strong prognostic predictability in terms of detecting subclinical cardiotoxicity. Just want to make sure I'm okay with time. Now, something so echocardiogram, now this is my area of interest in terms of research. This is something we're actually working on currently. So what there was a publication, and Dr. Tawakol from I think Mass General has done good amount of research in detecting vascular inflammation on cardiac CT, not cardiac CT, the CT that's done for PET CT that's done for oncology. So what we're doing is we're looking at certain segments of aorta. Let's say you define like ascending aorta after maybe the 10-15 slides above aortic valve, and then you go up and start measuring. And as long as you're consistent, you can measure these things and then report the SUV. So you can look, you can open up the PET CTs from oncology patients, and almost all oncology patients do get PET CTs just for the staging purposes, and then surveillance of response, and then monitoring after they're done with chemotherapy. So we use that that strategy, and we're trying to repurpose the the PET CT to detect vascular inflammation from various kinds of chemotherapy, including immune checkpoint inhibitors. So what we're doing is exactly what they have done. But this study was done on a patient with the Takayasu and the psoriatic arthritis. So we're taking this approach on oncology patients, and we're trying to figure out, see if we can detect inflammation and see it correlates with MACE, major adverse cardiovascular events. We're still collecting data, so we don't have any results yet. But I think by end of this summer, we should have something to present in terms of the abstract or manuscripts. What we're showing, another use of PET in general, not PET CT that's been done for surveillance, is we do have PET scanner. We don't own it, but we co-read with radiologists. We are assigned 2 days. And I commonly, my preference, if insurance is not an issue, I order PET CT as a stress test modality for perfusion over SPECT. But a lot of times insurance company hasn't recognized the value. But regardless, what the purpose of this slide is to show you that PET CT or PET CT stress test has been instrumental in detecting microvascular disease from anthracycline patients. So anthracycline is now, the attention has been given in terms of microvascular disease, and we're doing a small study to understand what's going on and how do we use it in clinical practice, what is the cutoff, and how do we how does it translate into outcomes. So here what I'm trying to show you is you look at the rest value, the myocardial blood flow in coronaries, and then at stress, and then you take the ratio, which is here. So post-exposure after anthracycline, the patients had a reduction in the myocardial flow reserve. So that's correlating. Whether this correlates with clinical outcome is uncertain, but anthracycline has been shown on multiple studies to affect the myocardial flow reserve, and that's something we can use. So I'm taking, as you can tell now, I'm taking each modality, and I'm just trying to show you how can we use each modality. And it's important that when you have a cardio-oncology program, it's supported by a strong imaging program. You can, it really supplements what you really want to accomplish with your patients. Otherwise, you might be sending the patients to different locations, and patient may or may not like it. We try to keep everything under one roof. And in fact, my cardio-oncology clinic is in Cancer Center, not in my heart and vascular clinic. That's where my general cardiology clinic is. So here I'm trying to show you, and I'm not going to go into detail, but you can see the utility of cardiac CT on different types of the patients. And this patient, the one in the lower one in yellow, that the patient had an extensive calcification, and we started a patient on statins, as opposed to this patient who had low platelets and could not get cath. And we're trying to diagnose what's going on with the patient. Unfortunately, the thrombocytopenia persisted despite diagnosing with multivessel disease. The patient could not get cardiac cath or bypass surgery for symptomatic, basically shortness of breath. And this patient who interestingly had thrombus sitting in the coronaries, but the patient was mildly symptomatic, and only thing that came back positive was troponin. The patient, did not want to go for cath because she just did not want to. Nothing to do with her hemoglobin or platelets, but we got her CT scan, and the image is not great. It's just a lot of motion, but what I'm trying to show is there's a subtotal occlusion of the RCA here. So CT is very useful. And now I'm not an MRI expert, but I'm just going to try to tell you what's going on here. And so the MRI is picking up in our hospital, and I'm sure elsewhere too. There are a lot of places who use MRI to detect cardiotoxicity, mainly immune checkpoint inhibitor related myocarditis. In general, so this study was done just to assess how can we use and what MRI biomarkers, imaging biomarkers that are predictive of cardiotoxicity. And native T1 mapping was superior than native T2, and even GLS. Now, GLS we use commonly with an echocardiogram, but they can also use GLS with the MRI. And in this particular study, the MRI was superior than the native T1 signal was superior than rest of the biomarkers that are listed there. So MRI is getting popular in cardio-oncology, but unfortunately, not too many cardio-oncologists, not that they don't want to order them, but I think it's just the problem is cost, and the test is lengthy, and you still can get tons of information from echo itself. So again, these are some examples, both published in our institute. You can diagnose drug-induced myocarditis on the top images, and you can use tissue characterization is the big thing with MRI. And this person was diagnosed with angiosarcoma, and then obviously if you cannot get any other things to work, you can use the stress test for stress test, MRI for stress test. And here you can see there's a perfusion abnormality in the LED distribution. I don't use MRI this frequently. My main utilization of MRI is in this space, drug-induced myocarditis. But I do use it for tissue characterization if I'm suspecting, let's say, metastasis to pericardium or something of certain patients. But again, I don't use it. Echo is still my go-to test. Again, I'm just going to skip over. So MRI can help you, and I think there have been studies and some data, not in cardiotoxicity or cardio-oncology, but in general, that MRI can help you diagnose microvascular damage. So I think MRI is going to be very popular in the near future because it's going to be, it has tons of potential. But I think right now, I think it's limited by the lack of expert readers in any given institute. But if you have that set up, I think it's a great test. So, so just to say, in the present time, you have ECG, you have echocardiogram, you have PET CT, cardiac CT, and cardiac MRI. Obviously, your biomarkers, but I'm talking about imaging modality. Now, let's take step. Where do we go from here? So again, past is all about detecting clinical cardiotoxicity after it manifests. Now, present, I think we focused on subclinical, detecting even small changes in GLS or native T1 mapping that alerts you that the person might be developing cardiotoxicity. But where do we go from here? Now, simple approach is like, continue what we're doing, or we can think about how can we use the data that's available to us and take it to the future. So any given cardio-oncology patient has clinical data, he has biomarkers. I didn't realize pointer was not there. So clinical data, you have biomarkers, blood work, tissue biopsy, you have PET CT. This is what we're currently working on. You have CT scan, even though this CT is not gated or it's not for cardiac coronaries, but you can detect calcifications and you can start preventative strategy. MRI is there, strain is there, genomic sequence is there, and obviously ECG is there. So, I think, and it's just speaking from anecdotally, there's no particular one test is better than the other. I think the combination of tests is the key. So with that hypothesis, we are working on a lot of other things. So one of the project that we undertake, and this is something I was, interested in doing from day one when I took the job as a cardio-oncologist. Currently, we know that the focus has been on anthracyclines and trastuzumab and certain types of chemotherapy. But one thing I wanted to study is like how patients are, when patient comes to me or oncologist, who should refer the patients to me, and who has a higher chances of developing cardiotoxicity, or they have a future risk of cardiac problems down the road. So we studied like 100,000 patients on a publicly available data set. And it's a cross-sectional study, so this is not a prospective study. Then, we started with 600,000 patients. We applied some exclusion-inclusion criteria, and then we ended up with like 3,500 patients. We tried to run the model with these, and I think it was computationally very challenging and heavy. But so we did like some feature reduction, and then we we cut down the population to 100,000 patients. Then again, we were dealing with like 11,000 diagnoses. So that's again too much. Like if you look at your Excel file, it's a CSV file. It was wide and long, and again, it was not computationally feasible. So we did some feature selection, and we did up. So when I say feature, mainly we're talking about diagnosis. So after doing some manipulation of data, we ended up with 4 distinct clusters. Now this manuscript is under consideration, so I cannot tell you the exact details, but I want to take this opportunity to tell what we found. And what we found is we found 4 different clusters, and cluster 2 and 3, as you can see, are very similar in terms of their composition of cancers. So I said, okay, well, why the machine did not delineate cluster 2 and 3? They have similar cancer. Now, if you look at cluster 1 and 4, you can see that there's a breast cancer and GU cancer, which are distinct from the other cancers. And cluster 4 was, interestingly, very clear-cut hematologic cancers like leukemias and lymphomas. So the question to me was why machine was not able to separate 2 and 3 and different types of cancer like 1 and 4. We got into more details, and we found that the typical cardiovascular risk factors, smoking, dyslipidemia, hypertension, diabetes, etc., was substantially higher in cluster 3. So the major determinant of cluster 2 and 3 was risk factors. And then when we looked at what kind of cardiovascular problems they had, the cluster 3 had substantially at least 4 to 8 times higher cardiovascular problems. That includes acute MI, stroke, basically MACE, essentially, and in hospital deaths compared to cluster 2. So that tells me that, I know we currently, a lot of literature is focused on breast cancers, because it's, obviously it's very important and very common. But to me, and this reflects my current practice, is that majority of my referrals are coming for lung and prostate cancer, not because they are on some very cardiotoxic drugs, but they do have a lot of cardiac comorbidities with it. So that tells me that I think in these type of patients, I think focus should be on addressing risk factors rather than just focusing on every breast cancer patient needs to be referred. So to me, this reflects my current practice, and this will change my practice in terms of how I design and how I tell my oncologist colleague to who should they send immediately to me, not urgent, like it's not like a stat consult, but who should I have more opportunity to improve their outcomes in the future. Now, echocardiogram, currently we have 2 main ways. You have ejection fraction, and then you have strain imaging. And those are the 2 ways of detecting subclinical or clinical cardiotoxicity. But what we are interested in, again, this is something, the radiomics is not a foreign word to Rutgers, and Dr. Yalamala and Sengupta are very interested in. And one of their early paper inspired me to look into these, type of data. So what we are doing is, briefly, is we are, we took a personal long axis view. We got their, radiomic manually extracted data from the septum and lateral wall or posterior wall. And then we knew, this is retrospective study, so we knew who had what, and we integrated with clinical data, and we made some prediction models. Unfortunately, I cannot share the data. I think it's we just revised the manuscript, so hopefully once it gets published. But I think we were, and also representing an abstract at American Society of Echocardiography this next week, I think. So, but yeah, the data was favorable for the radiomics data was able to predict risk of heart failure in breast cancer patient receiving anthracycline and trastuzumab. So this did help us in advance. Another thing we're doing, like I said, PET-CT is something my passion. So what we're doing is we're taking imaging, the data from cancer patients who underwent PET-CT before therapy, during and after therapy, and we found a way to automate the process where we just look at the lumen, not extra tissue, and you have these, and we're doing radiomic analysis. This is still we're still working on these. We develop a pipeline, let's just say. And we're trying to extract more data because we need more N values to make a stronger prediction. So that's something we're working on. We're just leveraging AI and radiomics to do the same. Now, initially when I conceptualized this project, and I was thinking, how can we use these data to predict an outcome? Because we're not really looking at the heart, we're looking at the aorta. But I think there is a tons of data, and we published this review article that got accepted, I think late last month, and we hypothesized that there it's not just cancer and chemo only, but there are other risk factors, and there are protein and genetic dysregulation that happens that we're not seeing, obviously, and we're just looking at the outcome as a endpoint. But there is an opportunity to predict something changing after each chemotherapy cycle, or certain intervals when they go for these surveillance PET-CT. We can use that data and integrate it with other data, and somehow we can use that data to predict certain outcomes. So in our review article, we clearly mentioned we figured out I think just 4 or 5 endpoints such as CAD, stroke, aneurysms, and hypertension, and then we basically talked about that. So yes, I think the vascular inflammation is a real thing, and from chemotherapy, and potential we can. So far, nobody has linked what happens in the aorta and that predicts the outcome using AI. So right now we're working on it, and potentially we can collaborate if the interest is mutual. Now, one of the major thing, and Dr. Singupta kindly mentioned the grant we received from the NSF seed grant. And the grant basically is to study how we can use ECG signals to predict cardiotoxicity. Now, before we do go into that, we wanted to develop a novel method that can is better than current standards. So what we did, and again, this is very technical paper, and it was written mainly by my colleagues, and I was able to contribute, but this is a purely technical paper. And I want to give credit to my colleague, Dr. Lay from University of Arkansas, who are collaborating on a lot of similar projects. So here, basically what, there are two kinds of contrastive learning. Contrastive learning, in essence, means it brings the similar features or similar characteristics together, and once they are distinguishing features, they keep them separate. For example, here, these are cats. Now, these are transformation. Here we just, in picture, we just remove the tail. Here we change the color, we put in the embedding space, and it gives positive attributes, because we're saying, because it's a supervised learning, we're just telling the computer that, hey, these are the same, the transformations. And then we're saying, okay, these are not, because this is like a lion or tiger, and this is a pig, and this is dog, which are not cat. But problem with self-supervising is sometimes it can cause false positive or false negative in this case. So this is cat indeed, but it's not captured for some reason. So that's why we used, it's not a novel, but I think it's very creative, supervised contrastive learning. And then the the cat was identified and it was late because we're telling that this is cat. So it learns to identify who are positive attributes and which are negative attributes and keep them separate. So it improves the ability to predict the true positives from and true negatives from each other. Now in order to get to that point, there are some transformations we have to do. And again, it's technical, but I'll try my best to explain, but this is very, I'm not doing a justice to what they have done, technically speaking. Now, we know this ECG signals, lead one in AVF, and this is called symmetric transformation. So we're trying to change the way it looks without losing its meaning. Now, to me, when they first ask me, like, hey, how does this look? And I'll say, well, this is trigeminy. It does no longer looks like trigeminy, but the purpose of this is not to predict which is bigeminy or trigeminy, but we're saying to the computer that this is exactly the same as this one. And why it matters? Because it just learns in a different way, and it can challenge the current algorithms, we call SOTA, the state-of-art ECG classifications, like based on neural networks. And what we're trying to do is we're trying to make the machine even more predictive. And indeed, we did that, and it, if you look at these ROC values, they're substantially high. Another thing we did is to analyze ECG signals from AI perspective or ML perspective. There are two ways, or popular ways, I should say. The time series module, and what it does, it takes all these signals. Even though we're seeing it like a straight line, there are a lot of signal frequencies that are encoded, and we can use a special software that you can decode them, and that pops out in a Excel sheet as numerical values. So, but it's technically, clinically it's irrelevant when you look at that, but you can generate, if you plot out those signals, it will look like an ECG signal. So anyway, so the time series module uses the frequency, and then on y-axis and axis is time. And there's another way you can do is a spectrogram, which uses energy, or the amplitude, of the ECG signal. So sometimes it coincides with it's like a heat map, So in this particular case, let's say the green or green orange, green yellow color is has a higher energy than the other areas. A lot of times it coincides with QRS, but it doesn't have to. Doesn't matter clinically. Again, it's not that important. But what I'm trying to show you is you can have, what we did here is people generally study either or. What we did in one paper we just presented, we actually used time series module and spectrogram module and put them together, took the best of the both. And then we had metadata such as age and gender, just because we didn't want to keep adding a lot of variable. Even though it seems trivial, but it's a significant jump in terms of accuracy. And it was statistically significant, needless to say, but we're definitely slowly and steadily improving. We just compared the 4 different methods, and when you add everything, metadata, spectrogram, and time series, you improve the accuracy. Now, the reason I'm showing you is not to show off okay, what we're doing, but this particular paper gave me an idea. Now, we're just using metadata and ECG signal analysis. What I wanted to do is try to integrate more than one imaging modality the same way we did here, and see if that predicts cardiotoxicity even better. So this paper, in a way, differently, helped me to design another project that we're currently working on, but it's very infancy right now. So I hope I'm going to give you some time to questions and answers. So my personal approach is using anything that's available to me to understand how I can improve my patient's care. So the theme of this, as I said, building paradigm. So to me, the way I took this, the theme that Dr. Sengupta created is how can he didn't say challenging or, destroying the current theme, but it just said building new paradigm. So the paradigm of the past was, clinical cardiotoxicity, then subclinical. For me, what's more important is what can I tell patients when they come to me in clinic using everything that's available to me that you see on the screen? And how can I tell them okay, your risk for cardiotoxicity is X percentages, or likelihood of having heart disease or heart attack or heart failure next 10 years from where you are right now. is whatever percentage is. To me, that's more powerful than just keep getting an echo and saying, oh, so far you good, look okay. But then to what point you're going to stop doing echoes, or how frequently you need to get echoes. One thing that we've just started doing is a genomic, and we just got an internal grant of like 100,000 to study anthracycline-induced cardiomyopathy and how that affects genomic profile. But what I'm interested in is not just like saying what happens to their DNA sequence or mitochondrial DNA, but I want to try to link it with imaging. So you can say radiogenomic or genoradiomic approach. But this again is just at the grant level. We just got it, so we have a lot of work to do. In general, when you talk about AI, and again, this is just a general thing, it doesn't necessarily cardio-oncology. It's important that we maintain privacy, because needless to say, you know, when you're currently in AI world, your phone and knows more than you do. And I think you probably come with a joke, like, you know, come across a joke when you ask Google, like, hey, what's my social security number, and it will tell you, you know. But I think it's a fact. So your privacy is very important when we deal with more AI. The patient should be agreeable to use their data. I mean, if it's a retrospective, not so much, but how you use their data is important, especially with the genomic and all these things. The data must be, so the project or the design of the study should respect the fairness in AI. What I mean by that is, you know, it inclusive of patients from you know, different backgrounds, diversity, and not just meaning ethnics, you know, or racial diversity, but more like geographic. What may be applicable to Appalachian or, you know, WVU doesn't mean it applies to New Jersey or vice versa. So you know, we have to respect the fairness in AI, and there is a whole field of fairness in AI, and the data should be generalizable. I can take this model and come to Rutgers, and it should predict more or less similarly what's predicting at WVU. Otherwise, you know, your project is only institutional specific. Now, I'm not a Tesla owner, or I don't own Tesla stocks directly, but I like this quote, and it just stuck to me when he tweeted this: prototypes are easy, production is hard. What I mean by that in my context is, you know, I can make any model or any algorithms that predict certain outcome, but how do we take these and apply to the rest of the world, or, you know, institutionally? So, you know, the building model, that cluster was easy, but does that cluster apply to Rutgers, or, you know, California, or India, or, you know, China, you know, other countries? So, you know, that's something we still have to do. So again, this is very basic level, you know, work done. And I think, but my focus is on the assessing the risk and prediction of the risk, as opposed to just focus on like a subclinical cardiotoxicity. So with that, I'm just going to post the question again, and I won't answer. I guess you guys can answer, but I don't know if I'm supposed to answer because it's a quiz, but you got the idea. You know, I think one modality is not superior than the other, in my opinion. Thank you again for your attention and invitation. Hope I know, didn't run over too long. I know I'm between you and your dinner/family, so.
Thank you, Brijesh. If you can unshare the screen, that would be great.
Okay. Did it work?
No, we still see your screen.
Only option I get is share or new share.
Okay, I stopped it.
Perfect.
Thank you. That was a perfect quote to end on. So my first question for you, Brijesh, is prototypes are easy, production is hard, right? Mm-hmm. And given that you're trying to pull multi-modality information as well as multi-dimensional data together to make your prediction. So mm-hmm. how do you envision this implemented in Epic or EMR systems?
So one thing I'm trying to do, at least we started with, you know, I talked to, luckily the administrators found me. I don't know how, but they found me, and they said the IT side of it. And they said, how is it possible to use the same idea in Epic? And mainly they were talking about ECG, because we have that database, and you know this database too. So right now we're working on it, but I think the ECG has to be on real time. So this data is like, you know, retrospectively collected and gathered. It doesn't mean much if I get a new EKG on patient tomorrow, right? So, you know, first thing you have to do is like somehow I'm not sure how they're going to implement model or algorithm specifically on Epic, but that is something we are slowly working on. But the first thing is like develop a model that can predict something. So that's something we're working on. One of the the AI guy is working on it. The next step is, take this data, either present to our administrators and say, hey, is there a way we can API it or something that, we can get these signal data in real time. And then that's something I don't know, nobody has done it, but something we might be the first one or one of the first ones to do it, if not already been in the process.
Thank you. It was an excellent presentation, and it started generating a lot of, because I did not see the contrastive learning before, and you just heard from you for the first time about the success of ECG prediction using contrastive learning. Now, one of the questions that comes to me is that when I looked at your architecture, it's very complex in deep neural networks. It uses both CNN as well as LSTM, two complex structures of deep learning again. So, and then when I looked at your performance, beautiful performance, 98%, right? What more can you expect from it? But contrastive learning, because of its nature of unsupervised versus semi-supervised learning-based technique, because of that contrastive nature that is embedded in the architecture, it is prone to noise and artifacts in the data. And given that the ECG field is such a artifactual driven by changes in the motion or muscle and everything, how do you think that you could counteract that for generalizability of the model at different centers or multi-site? Have you done that?
No, so we did not do that. So, but I completely agree, and I did not want to go too much in detail. Just didn't want to bore my audience with this, and it's not something my forte, anyways. But we did, there's a WNS. Basically, what we did is that we did apply another transformation that reduces the noise in signals. You're right on, because that's something I brought up to my colleagues. Then I said, ECG is more prone to noise, and they said, oh, we know the solution. So we did do that, and I don't want to go back and show you, but it's in my slide. And if you look at it says SCL-WNS or something. So that is a noise reduction transformation. So we did do that, and again, it's still show very high, in the magnitude of 90 something. So it was up there. So we did do that, and I think that's important that. Because what we did in that particular paper was we challenged, in a way, you know what I mean? So we tried to show that this approach is better than what the state of the art or current method of evaluating ECG signal is. So we did do that, and we just, for that particular paper, we only predicted rhythms and left bundle branch block. So we did not apply to cardiotoxicity yet, but we're doing it now. I think we have a PhD student who's working on that, exactly.
Yeah, so there is a question from Dr. Maganti in the audience. She's actually raising a question. When you smooth out, which means too much noise removal, are you going to lose patterns that are meaningful?
Yeah, so that's that's where and again, Navina, correct me if I'm wrong, but I think I don't know the technicality side of it too much, to be honest with you, but we did address this issue by some supervised, that's probably the benefit of doing supervised part, where you keep saying, have a label. So even though you lose data, if it's a meaningful data, then yeah, it's hard to retrieve. But I think, yes, you can lose data. So something that was brought up in our meeting too. But how do we know how much we have lost? I think either we got lucky with what we did, or maybe the advantage of like supervised and label data is that I think whatever we have left, we can still train on what's remaining.
And how do you ensure the model was not overfit? Because again, the structure of me thinking two complex deep learning architectures were combined, and then the denoising was applied, which means that the data is very clean to train with. So how do you ensure that you're not overfitting the model and more generalizable to the public?
Correct. That's always a risk, and I don't think we assessed specifically whether it was overfit. But again, what we did for that particular project. There's a database called PhysioNet 2020. It's publicly available. You can download the data and play with it, type of thing. But I think that becomes very important when you actually use this data on a real patient data. Those are real patients too, but like cardiotoxicity and all these. And that's where I think the generalizability is important. So what I do here, and it does not work at Rutgers, to me, it's very institutional or model specific, institutional model specific, and it's not applicable. To me, that's a big thing. Anything I do is, I'm not saying generalizable, like in a sense, like rest of the world, but like selected population, it should apply. And it's somewhat personal in a way that, a lot of trials, me being from Indian origin, a lot of data we use is from America and Europe. We don't have our own database, right? So that always comes up when we have like the doctors who gather in just like a friends meeting, and we talk about like what should we do, and we always bring this up, like this thing is not generalizable to us, vice versa, and the data may be different in different population. So that's something is my personal task as I dwell into more of type of this project, is to make sure that we have a diversity of data, if that makes sense.
Thank you, Brijesh. One last question, Brijesh, from the audience again. So are you able to retrieve raw echo data when you feed it into the model, like example, strain and other parameters?
There's a way, but we did not do it. I'm not sure if that's where we're going to go next in terms of the follow-up question, but I think one of the things I want to do is I want to try and test radiomic data with strain data, because strain from echo is the best way to detect subclinical cardiotoxicity. Like I said, native T1 signaling an MRI, but it becomes too expensive to get an MRI, and it's not practical for a lot of centers, but echo is, right? You can use TomTech and do that. So yes, there's a way you can, because ultimately all the data has been collected in digital form, and you can retrieve it in digital form and then process it. I have not done that. I'm not sure you guys over Rutgers, you guys are, big hub for radiomics and echo, so you probably can answer this question better than me. But next thing I think is to compare radiomics to strain and see if that has any, does radiomic add any value, or, take you to the higher and better predictability.
Thank you. And one more question, what radiomics features did you consider to evaluate the MRI data when you were showing it?
MRI we did not do yet. I mean, MRI is something we have not even looked at. It's because
for CT?
CT, yes. So we use PyRadiomic package. So we have just trained the model, like just not a train. We just wanted to do the test run to see if it's practical and feasible before we collect data on like 800 patients or so. So we're doing it now, and I think it worked. The pipeline worked in a sense like you feed the image, and the PyRadiomic comes out with an Excel or a CSV file. Then something you can link with your clinical data or E-number or whatever, MRN number. So for something that, and we considered, I don't know if you meant like first order, second order. Yeah, so that's what we're collecting. Whatever comes in PyRadiomics at that point.
Thank you. And, I'm still thinking about your first slide that you started with the clusters and speciation of different groups, how the two types of like the lung, pulmonary and prostate cancer had two clusters, while the others delineated into the other smaller clusters. And so given that oncology itself or cancer itself is multidimensional disease, how are we actually, by speciating them or grouping them into multiple things, are we going to look for specific biomarkers, or what is the vision that you have to move forward with?
Yeah, so, that's a good question. So I think I spoke with our CTSI, the folks there. So what we did is like, because to me, lung cancer and heart disease are closely related. Now you can say that smoking is number one, cause, but that's not true. So what we found is, well, obviously smoking was one of the, the risk factor that I showed, but what we found is like the other comorbidities also matter to highest level. Whether we don't know how lung cancer and cardiac disease are linked because they have common shared factors, or something, diabetes or hypertension, there's a has a modification effect, and that causes both two different disease conditions in certain patients. So right now we're using a genomic approach to understand what is, I mean, again, we have not started it. This is something, it's just fundamental, and we're just discussing, just barely even scratching the surface of these, and just to understand how they're genetically related, those two patients. So we're not there yet. I don't know, but gene is one biomarker that we're using.
Thank you so much, Brijesh, for such an, how should I say, for creating new neural networks in my brain. It was very, very thoughtful talk. And, I'm sure that it has left everybody with the impact of thinking in multidimensional way of how to do like this kind of omics research, combining different modalities, including EP or like ECGs, imaging data, and genomic data. So with this, I would like to thank you for coming to our grand rounds and presenting today. And this would be our last grand rounds for the series. Oh, so you are our last speaker for this entire series. We're going to take a break for summer, and we'll all see you back on September 11th towards our fall season. Thank you, Brijesh. Thank you, everyone.
Thank you.
Have a nice
thanks
evening.
For staying this late and listening to my presentation. I hope I didn't bore you. And, it's a good segue for dinner.
No, it was really good one to actually give some food for thought for the summer for everybody. Thank you, everyone. Have a nice evening. Thank you, Brijesh.
Thank you again for inviting.